Well, welcome back to my evidences and welcome to the European Fertility Society. I'm very happy to be back with you this week. This is our second event this week, and I'm really glad that you were able to join us already. As you can see, we have another expert and we have another topic to discuss. As you can see, Dr. José Félix García is with us tonight. Hello, Dr. Garcia. It's great to have you. It's your
Hello.
are on this English platform, Maya Vivence's English platform. So I'm glad that you will present this topic tonight. How are you feeling?
Fine, thank you. Willing to start, and thank you for inviting me.
Thank you so much for joining us tonight. As you know, we will talk about hysteroscopy, and Dr. Garcia is here to explain it to you. Here's to suggest when it might be needed. And as you know, our topic is it a waste of money or is it a real help? And of course, Dr. Garcia is here to answer this main question. But as you know, we will start with his presentation, but afterwards there will be time for your questions. So all you need to do is just type those in the chat section so that Dr. Garcia can help you with those after his presentation. Don't forget, this is actually our final event this year. Don't worry, we'll be back next year. So please use this time. Anything that's on your mind, anything that you want to ask. We are here to support you, as you know. So don't hesitate, of course. And before we start, I also wanted to add that we are still looking for volunteers. So if you know someone or if you might be interested in helping us with descriptions, we are looking for people that can help us with transcriptions of the webinars, past webinars. Please get in touch with me. I'm your host, Caroline. You can find my email in the chat as well. And I hope you will be able to help us, or at least you can have a look if this is something you can help us with, okay? But now I think it's time to start our event. Let's get on the topic tonight, hysteroscopy. Dr. Garcia, are you ready to begin with the presentation?
Thank you very much.
Thank you. Indeed, this is the presentation. You can go ahead, of course.
Thank you. Okay, well, first of all, I'm glad to be with English people again. It's a long time that I left England. I did my specialty there, most of the time in Northwest, in Manchester. And well, I did my specialty there, and I'm MRCOG, member of the Royal College. I was training since 1991 till 1997. And in 95, 96, I obtained the membership. And then I came to Spain and I started working in infertility. That was not my plan, because my training was in England more in general gynae and also in urogynecology. But then when I came to Malaga, then I started working in 1997 in infertility. Well, the question that you asked me today is a very interesting one, because if you have the doubt whether if it's useful, it's a waste of time or not, that is the same problem that many specialists that we have also in many aspects. And that is what I want to try to clarify today, because we have doubts as well in some ways. So first of all, what is the hysteroscopy? Well, hysteroscopy consists of just to have a look inside the uterus and to see if the anatomy is normal or if there is any abnormality that may be operated or sorted out in some way. But there are two types of hysteroscopy, and that is very important to differentiate, because probably your question is aimed to diagnostic laparoscopy and not surgical one. So we have two. We may just have a look to see if there is something abnormal, or because we know already that there is something, polyps or some abnormalities that we are going to see now, then we are going to operate them. So before going deeply in this problem, well, here you may see just the draw of a picture of the anatomy of a woman with the uterus and the speculum, and how the hysteroscope is coming inside the cervix, just to have a look. And then on the right, you see what a hysteroscope is, and this is a surgical one. As you may see, well, the surgical one is thicker. That's why in this surgical procedure, the woman should be under anesthesia, because to dilate the cervix is quite painful. and then you may see two tubes coming into the first two connections are the fluid necessary to clean the uterus inside, so we may see what we are doing. So on one side, the fluid is coming in, and then we have to continuously cleaning the cavity. Then a bit more backwards, then we see the connection of the diaphragm or electricity, just in case we need to coagulate a vessel or to cut anything. And then finally is the light source, where we see that this is the light, the last tube that we may see there. Well, this is a surgical one, and the diagnostic laparoscope is very similar but thinner, and there is not a small tube adapted to operate. It's just to have a look inside, and it's thinner, so the diagnostic laparoscopy can be done with the patient without anesthesia in the clinic, without going to the theater. And this is what we may see in a hysteroscopy. This is the uterine, the uterus inside a normal uterus. I wanted to show you what a normal uterus looks like. This is the endometrium, thin endometrium. Probably is a woman who's having this laparoscopy after the period. And then these two holes on both sides is the beginning of the fallopian tubes, as we see them through the uterus, and not in a laparoscopy. We may see another picture, another looking, but here, yes, we see the entrance of those fallopian tubes. Right. So here the main problem, and that's why probably you ask if it's useful or not, is that when a patient comes and she is infertile, or she's trying for a pregnancy for a year or so, then we say, well, should we do a laparoscopy? When, in what circumstances we should recommend a laparoscopy? Well, let me show you something. This is, for example, is a paper, hysteroscopy prior to the first IVF cycle, systematic review and meta-analysis. And it was published some years ago. It was a very well-known paper. And then they say in conclusion, this systematic review and meta-analysis of published control studies suggests that hysteroscopy in asymptomatic women prior to their first IVF cycle could be associated with improved treatment outcome when performed just before commencing the IVF cycle. So they say all women that comes to the clinic, whatever problem they have, just for infertility, we should have a look. As we do a spermiogram, then at the same time, we should have a look with hysteroscopy, but because if we do that, then we're going to improve the results later. Although always they say in almost all papers, robust and high quality randomized trial to confirm these findings are needed to further guide clinical practice. So they say, well, we have to study a certain number of patients, and our study is limited, and we think that it's important to do the hysteroscopy, but we are not completely sure, and I think that more studies should be done. Well, I'll show you another one. Efficacy of hysteroscopy in improving reproductive outcome of infertility couple, systematic review and meta-analysis. And what are the conclusions? In our systematic review, we found that the opposite. There is no evidence about the role of hysteroscopy as a basic infertility evaluation tool. It is unclear whether hysteroscopy performed before IVF, regardless of intrauterine abnormalities, improve live birth rate because of the very low quality evidence. So some papers, some gynecologists or experts in hysteroscopy, as they advise you to do it, and some they don't. So what to do? So you have doubts and say, well, it's a waste of time because they ask me to do a hysteroscopy and they find nothing, and I have to pay some money and well, not to go to a theater, but this is not comfortable. I'm doing something that is worth doing. On top of that, and we will see that a bit later in a few minutes, there are some pathologies or which are not defined whether they are important or not, and they're very typical to be diagnosed nowadays. Well, and I like this one. Hold on. Okay. Because we are now in a short group, and sometimes we shouldn't say these sort of things, but I think it's important for you to understand the pressure that sometimes the doctor have when we have to decide. And my thought was, what happened when after a failure of implantation, we decide, a woman has come, and we didn't do a hysteroscopy because we did the basic studies. It was not recommended under our point of view. And we have transferred 1, 2, or 3 embryos, or even she has performed 2 IVF already. And then we consider that that patient has the problem of failure of implantation. And as we are going to ask further blood tests or chromosomal studies or prenatal diagnosis, whatever, then we say, well, we are going to recommend a hysteroscopy. And then once we do it, then it comes out the result that the specialist has reported that she may have a chronic endometritis, which cannot be seen by ultrasound scan, or dysmorphic uterus. If you don't know what a dysmorphic uterus is, it's a uterus which cavity is not that triangle shape, but in a T shape, for example, or E shape. It's not the normal shape. Well, what will be the patient reaction? Doctor, now are you demanding me? Are you asking me to do this after I've spent a lot of money in my wife, or I've had 2 miscarriages, and I don't know how many embryos under stress. Now is when you ask me for a hysteroscopy, and then I had this problem and you didn't diagnose that. Why didn't you do this before? And then, are these entities real pathologies? What I told you. Well, it's very difficult to tell the patients, as we don't know, and there are papers in favor of doing a diagnostic laparoscopy just at the beginning, and others who says that it's not important. This dysmorphic uterus or this chronic endometritis is under discussion, and probably it's not that important. But now that we know that, we have to do something. Give you antibiotics, operate the cavity of the endometrium to make it larger or more triangle, more physiological. But now probably that pressure, you may understand that probably in the National Health Service, where you have very strict protocols, you do this, you do that. I've had 2 miscarriages. Sorry, till I work in England, and I remember that talking about miscarriages, we didn't start investigating if there were a repeated miscarriage problem unless the woman had 3 consecutive miscarriages with no live birth. And that was the protocol, and that's it. But now you come to our private practice and say, well, doctor, I've got 2 miscarriages. Are you gonna wait for the 3rd one? Why don't you ask for a hysteroscopy? Why don't you ask for a blood test to see if I've got clotting problems that may affect the baby, things like that, and I need heparin, for example. So things are not seen in the same view in one side and in the other side. And it's not that in one side, one is performing a better medicine than the other, all right? So that's, I think, is the center of this problem. Is a waste of time. So we are in the process of knowing if it is or not in certain circumstances, because now we are going to see when it's definitely useful, all right? But when to do it, that is sometimes a real problem. Because if you come to the clinic and I do a ultrasound scan and I see something that possibly a polyp or an irregular cavity, something that I don't like, then of course I'm going to prescribe an hysteroscopy. But sometimes the endometrium looks perfectly nice, triple line if it's in in ovulating period, and we don't see the reason why we should do that. Sometimes if we do it later, we may find some pathologies that we weren't able to see it just during a vaginal ultrasound scan. So this is the dilemma with the diagnostic laparoscopy. So, and what happened with surgical hysteroscopy? That is another completely different problem. Now I can be more realistic and let's try to tell you that when there are some abnormalities, I mean, nobody, and you will see in a few minutes some pictures of abnormalities inside the uterus, that obviously if we've got fibroids inside the cavity, and we can see that first by ultrasound scan, and we refer the patient to have an operation to remove these fibroids inside the cavity, or polyps, or adenomyosis, as you know, it's the endometriosis in the uterus, and if that adenomyosis, that endometriosis is in the endometrium, inside the cavity, that abnormal endometrium may affect the implantation, and we may guess that the patient may have adenomyosis by ultrasound scan, or septums that divided the uterus, or adhesions. Of course, nobody discussed that to operate that, to leave the bed where we are going to leave the embryo, should be in the best circumstances possible, okay, in the best way. So here we got some pictures. The first one, for example, this is a septum that divided. You remember the first one? I'll show you the normal. Okay, this is the normal one. Okay, and now that woman has something that divide this cavity in two. Right, and then what happened? That if we perform an IVF and we leave an embryo here, we don't know if it's going to implant in the healthy tissue that covers the wall of the uterus, or here in the septum, or even when it grows, the embryo in the sac is going to have difficulties to develop, then to grow. This is a fibroid, which is a bit similar to a polyp, and it's the same. There are fibroids. Some patients that women that may be hearing this presentation now may have fibroids, but these fibroids are not inside the uterus. They might be in the muscles or outside the uterus. Those are not very problematic. This is not a big problem. But if they are inside the uterus, again, we shouldn't leave an embryo that we cannot control the place where they are going to implant, having that abnormality, that abnormal tissue. This is not cancer, of course, but may prevent the embryo to implant. And the same happened with the polyp. Well, and then I'd like to, so just in summary, what I've been trying to say till now is that diagnostic laparoscopy is a problem, and I suppose that is what you mean when you say it is a waste of time or not. And the thing is when to do it, and that we have sometimes the same doubts, because nowadays there is not a paper saying exactly when to do it, in what circumstances, etc. Then, what are dysmorphic uterus that we talked about this entity, this pathology just a few minutes ago. So here on the left, then you see the normal triangle shape of the uterine cavity. And sometimes, and this is something being described recently, a few years, 6-7 years ago, we never talked about this T-shaped uterus. We didn't consider that there was a problem. But then now that many hysteroscopy has been done, then, well, the specialists of hysteroscopy say, well, this is not a normal cavity. This shouldn't be like that. Or we don't know if a certain percentage of patients in population may have this shape, and it's not that important. But because it's not the typical triangle one with a lot of volume and capacity for the embryo to grow, then we think that this should be in this way and not like this. And here is a 3D scan showing this T shape or Y shape uterus. And then the operation in this case, when we send the patient who has not been successful with an IVF, and then it's reported that she has this sort of shape of uterus, what are we going to do? Right? We're not going to say, look, many patients may have this uterus, and that is not proof that it's a real problem, but we don't know if it is. Maybe in the next years, we may have the number of patients necessary and a good design study to confirm that. So in the meantime, let's operate it, because it's not a difficult operation. It's just with the diaphragm to make an incision at 12, at 3, at 6, and 9, and then the uterine cavity will expand. Then there are, again, papers, and I have to tell you who are doing these papers. These papers are published by specialists in hysteroscopy, and it's a very human way of behaving, that one thing that his or her specialty is the best one and is the most important one. So probably it's that the results may be a bit biased, but this intention of showing that is very important. In short, we need more studies to confirm that it is a problem. But if we find it, we have to operate it, right? Then, this is, again, I found an article in favor of this. This is hysteroscopy, metroplasty for T-shaped uterus, a systematic review. And then they say, conclusion, both in cases of primary infertility and recurrent miscarriages, the hysteroscopic correction of a T-shaped uterus was associated with high live birth rate and low miscarriage rate. Moreover, the procedure was associated with limited risk of intraoperative and postoperative complications. So they say that in their experience, the rate of pregnancy has improved, and this is not a dangerous operation, it's an easy way, so we will do it. And then the patient may say, couldn't you have diagnosed this before? Why you didn't prescribe a hysteroscopy the first day I came into the clinic? Well, however, because of lack of control studies available, evidence does not allow drawing firm conclusions, is what we always say. So they say, well, we have studied some number of patients, but we need more, and to select patients with where they don't know what we have done. And it's very difficult nowadays to design a very good paper work with the proper number of patients, and when the doctors and the patients don't know what we have done, is the best way to see the result without the influence of the observer. Right, so, and this is another pathology. This is the chronic endometritis. Chronic endometritis is an inflammation of the uterus and the endometrium, and the patient is completely asymptomatic, and we cannot see that by ultrasound scan. It can be diagnosed either by hysteroscopy, where we see this, as you see, this is small, very small polyps, and it can be diagnosed as well by a biopsy of the uterus and checking some markers and see if some germs are present or not. But as I said, this is not a serious infection. The woman doesn't have fever or pain or anything. And again, there are many gynecologists that whom, as there are many with the T-shaped uterus and dysmorphic uterus, they don't trust yet that is a very important procedure. Again, there are many people who says that in chronic endometritis, they are not sure about whether this is very important or not. Again, if we diagnose that, the treatment is with antibiotics, and it's a very simple antibiotics. And then, again, is it useful to repeat the hysteroscopy once I've had 10 days of antibiotics? Well, it's reported that some patients, after having had the antibiotics, they carry on having these micropolyps or this chronic endometritis, and sometimes it's reluctant to be in very rare cases. But normally, what we do in our clinic is that if we find it, we treat it with a cocktail of antibiotics, and then there are papers which says that in a 95-99% of the cases, the patient will be cured. And after that, we proceed with the next transfer. So here the thing is, should we follow standard protocols, sometimes not easily accepted by the patients? What I say about sometimes National Health Service. If I look at our guidelines of the Spanish Society of Fertility, they doubt about almost everything. In summary, they say, okay, do an IVF, a karyotype is useful, and 2 or 3 things. So if there is not a pregnancy, repeat it and repeat it and repeat it, because nothing has been demonstrated. At the same time, the patient who comes to IVF is a young couple or young patient between 20-something and 40-something. They manage internet and they ask you many things. Sometimes the patient comes here and they know about different techniques, what they have read in what he said, the endometrial receptivity, if we do this or we do that, and why don't we do this and why don't do that. And sometimes I talking to them the first time they come, even for an hour, not only explaining what I'm going to do, but only explaining what I'm not going to do and why. And that's a lot of time. So it happened that the same dilemma, as I said, well, I've explained already that, okay, about the NHS and the private sector. Then, I like that very much. It was an English scientist who said that 50% of what we affirm today in medicine will be refuted in 15 years' time. But the problem is that we don't know what 50% is. So sometimes we are affirming things, embryo glue, for example, the endometrial biopsy, immunology, the problem of incompatibility in between the couple, between the man and the woman, and probably, as it has happened with immunology already, in some treatments has been prescribed and now they are completely abandoned. And then, in sometimes, many of the things that we're doing now will be completely forgotten. So, this means my presentation. I don't know if I leave more or less. I wanted to transmit you our doubts, not only mine, but also the what we talk when we go to a symposium, and then we discuss that. Well, when should I prescribe hysteroscopy? Is this useful? So I wanted you to share with you our thoughts and our problems as well. Okay. So now I'm willing to answer your questions if I know them, of course. Okay. Thank you very much.
Thank you so much, Dr. Garcia. I definitely think it was useful. Thank you for introduction on hysteroscopy. This is not an easy topic for sure. It depends on many different aspects as well. So thanks indeed. But now it's time for your questions. So if you wish to ask something, go ahead, do it. There are some questions ready, of course, right here. So let me just show you the first one. We might need some more details, okay? But I will show you. Maybe you can still help. It must. Is it? Does it have to be done for IVF, before IVF, I guess? Because that I did 3 times. I understand failed cycles. And what are my chances if I did not do it? This hysteroscopy first, right?
So I understand that that patient had 3 IVF already.
I believe so. If you wish to follow up, please go ahead, type some more information. But I believe 3 failed IVFs, and has to be done.
Even in our protocols, even 3 IVF with 1, 2, or 3 embryos each time transfer, or just 1 IVF with 3 good blastocysts transferred, that we consider that as a failure of implantation, right? what is the definition of failure of implantation? Yes, 3 IVF. Well, I don't know how many embryos transfer, but that's enough. Okay, unless she has done 3 IVF with no embryo transfer, because the problem was in that case before the uterus, two embryos transfer in 3 IVF. Right.
I believe so.
Everything depends, so we cannot generalize. Okay, but this patient talking to us has had 3 IVF and only 2 embryos transferred. So this could be because she has a low ovarian reserve, for example. So they weren't able to obtain many eggs, and consequently, she had only 2 embryos transferred, as she said, and 3 times laparoscopy. Right. But what I said is that it's not the same. Here in this case, 3 IVF, as we said, and only 2 embryos obtained. So we have to ask ourselves the role of the uterus here. Is it the same? She had, yes, I've had 3 IVF and 3 embryos every time, 9 embryos. Well, then we have to investigate many things here, right? But what I was going to say is that the definition of failure of implantation is a woman less than 37 years of age who has had at least 3 embryos blastocysts, 5 days embryos of good quality with no pregnancy, or more than 37 with genetic diagnosis of those embryos, and she didn't get pregnant. At that time, that we may change it, we are free to change it, then we have to question ourselves, to think that there should be some problems. And then is when we say, okay, let's start studying the couple. I talk about failure of implantation, as we talked before this connection with Italian women a few weeks ago. Then we have to ask for the karyotype for the couple, maybe to do a fragmentation of the DNA of the sperm, fish of spermatozoids, just to see the genetic of the spermatozoids. Then that patient should have, in the next IVF, to have analyzed the embryos probably to see if those embryos are coming well or not, and at the same time to study the uterus with a hysteroscopy, a biopsy, if we trust in that range of implantation, the window of implantation with the ERA, for example, ERA, sorry, in Spanish we okay, and then why not to send her to the hematologist to see if she suffers from thrombophilias, which are discussed, the paper of that, or even to send them to the immunologist. Then we have to talk to the patients and do these things. So, because I have recurrently fibroids, and my last operation was in October. Well,
there is one more, okay? I plan to do another one in January.
41.
Yeah.
What are my chances? Right. Well, here, and I was figured that point was here. Well, she's 41. We know that after 35, the fertility start coming down, and after 40, that is more serious. And so at 41, the rate of miscarriages is more than 40-something%, and then we need about 9 blastocysts to have 2 healthy blastocysts. So the first reason for her not to get pregnant is the age of those eggs, the quality of the embryos. So here the hysteroscopy is secondary. So if we repeat an IVF tension, and then she has a genetic diagnostic of one of 2 embryos, and one of those is chromosomically normal, then I would do a hysteroscopy, because I got a gold medal there. I know that embryo is perfect chromosomically speaking, and then I don't want to waste it without checking the uterus, which is a normal procedure, a very easy procedure, without anesthesia, and why not? All right? So that is my opinion.
Thank you so much. Thanks for your questions, and thank you for your advice here. If there's anything else you would like to ask, of course, go ahead. I believe that was helpful as well. And let's have a look. We have another question, this time from Anna, with some more details here. My immunologist recommends a hysteroscopy. Even though there is no suspicion of endometriosis, I have polycystic ovaries, but had negative ALICE tests. But he says it's not because he suspects there is something wrong, more that a hysteroscopy can be good for other reasons before frozen embryo transfer. What are your thoughts?
Well, I don't know how in England they are working now. I'm surprised that it's the immunologist who is recommending the hysteroscopy. That is the first thing that is surprised to me, because our immunologists don't think about that. We send them, they treat the patients, and they normally come with corticoids treatment or more aggressive treatments. I'm not going to go into the problem now. And vitamin D, that normally we send them, etc. Some studies and a very large blood test, but not recommending a hysteroscopy. Well, even though there are no suspicions for endometriosis, I have polycystic ovaries and a negative ALICE, but because of the suspect there is something wrong. Well, again, if she has been sent to the immunologist, we don't send a patient to the immunologist the first day she comes to the clinic, into the clinic. It's because there has been some failures of implantation, there has been some embryos transfer already. And if she has been recommended to go to the immunologist, which is the last step. Okay, we call them here the shaman of nowadays. I mean, then when you don't know what to do, then you have done everything, go to the immunologist. Okay, so I wasn't sent there. I contacted myself. Okay, right, good, fine, I understand. Right, so it makes sense, right? Because before going to the immunologist, I would have done a hysteroscopy. But then if she has had 4 transfers done, or 4 embryos transferred, then, as I said, that is a further implantation, and I sit with them, with a couple, with her, and then we are not going to only send her to the immunologist. We are going to do some more things, right? And then, as I said before, I'd like to check the sperm of the couple, of the male. As I said, to see the DNA, etc. Right? But one of the things that, of course, should be done is hysteroscopy before having very aggressive, sometimes, and complicated treatments. That is what the immunologists normally recommend. Of course, yeah. 3 implantation failures and 1 miscarriage. All 1 embryo per transfer. Yeah, what I said. Of course, yes, but not only that. More things apart from the immunologist. Okay. That comes before, in my opinion. All right. Okay. Fine.
Thank you so much. Okay, Anna, hope that helps. Of course, if you have anything else you would like to ask, go ahead. Still time for it. In the meantime, let's have a look. More questions are coming in. So is it possible for fibroids to disappear without surgery?
No. I mean, with medical treatment, no. There are 3 ways of treating the fibroids. Surgery. There is a radiological intervention. We don't need to open the tummy or the laparoscopy, and just the radiologist introducing the vessels by, even now by radiofrequency, they may burn the fibroids without opening the tummy or doing a laparoscopy. But if we're talking, if we're talking about medical treatment, they reduce the size of the fibroids, but they don't disappear. Okay? With medical treatment, we may decrease the size or not, or making them not to grow more, but not to disappear. No.
Makes sense, of course. And next, there's a question about what size and location of fibroids and removing which ones are fine.
Which one are fine? Okay, all fibroids, what we call them submucous fibroids inside the uterine cavity, should be removed. Then, if they are completely outside the cavity, hanging outside, what we call like polyps outside the uterus, those shouldn't be removed unless they are extremely big, all right? So the problem are those fibroids in the muscles of the uterus, intramural fibroids. And typically, I said that if the fibroid measure more than 5 centimeters, sorry, I don't have inches now in my mind, 5 centimeters, and they are displacing, compressing, pushing aside the uterine cavity, should be removed. But some women may have 3 or 4 fibroids, or peripherically outside and not interfering with the uterine cavity, with the place where we are going to transfer the embryo. Those shouldn't be operated. But sometimes it's complicated to take the decision, and that is a clinical meeting where sometimes we have a meeting and we decide after all of us checking the ultrasound scan what is the best one. And sometimes even I send to another colleague expert to do a 3D scans and even to do an hysteroscopy and see the cavity from inside and see how much that fibroid is pushing or coming into that uterine cavity to take that decision. Sometimes it's not easy to take it.
Okay. And there's a thank you from Anna. Thanks a lot indeed. Next question we have is here. So why would clinics perform more than one hysteroscopy on a woman? Surely one would be enough. Thank you for your response.
Well, that's a good question. Sometimes we may perform 2, as we said, in chronic endometritis. Sometimes we treat it with antibiotics, but we don't know because we cannot see that inflammation, that affection of the endometrium by ultrasound scan. So we have to trust that after those 10 days of antibiotics, the problem is sorted out. So I understand that if that doctor, that specialist has the diagnostic hysteroscope in the consult, in the clinic, and they can do it in a few minutes, why not to do it, right? As I said, our protocols, we trust, we don't do that, okay? And normally, in some occasions, it could be necessary. In surgical hysteroscopy, sometimes, yes, we have to repeat it because there are fibroids which are coming inside the cavity and they can remove 25%. And a few months later, that fibroid has come more interfering. The other part that we left inside the muscle is coming again and we have to remove it again. But that is not very often. In my practice, we don't normally do it.
Okay, that's good to hear then, of course.
Once, unless it's an exception.
Of course. Okay. Thank you, Lisa, for your question. Next question. I'm not sure about this medicine. I'm not familiar with it. I might not know if you are familiar with that. Is it more efficient than hysteroscopy?
There is a medicine. I don't know what is.
Yeah. So if you can explain, or does it have a different name? If you can put it in the chat, maybe, because let's wait.
What does it mean? There is a medicine, RYEQO. I don't know what that is.
Exactly.
It is more hysteroscopy. I don't know what they are talking about with that. No, because I'm not working in England. Maybe it's, I don't know.
Exactly. That's why, if you would like to perhaps explain, we will go back to this question. Okay. So let's go to the next one in the meantime. I am almost 44, low ovarian reserve, 1 failed IVF, 2 embryos were transferred on day 3, saw a gynecologist after the failed implantation. I was told I had a large polyp, had hysteroscopy to remove polyp, and this month having PRP in Spain. Anything else you can recommend to maximize next round of IVF success?
That is perfect. I like this question with Wolf, but this is very long. We may talk about. There are many topics here. Okay.
Sure.
Well, do you remember what I said about the pressure and the new treatments that maybe in a few years we don't trust what we are doing now, etc.? Well, the PRP, it's a very good example, right? Our group in Alicante, they are doing that. EV, which is very well known, they have comments. They are doing this. But the preliminary results says that if the woman is relatively young, less than 38, maybe the platelets, what we call ovarian rejuvenation, which is not a very nice term, could be useful in the way that maybe instead of 4, next time we're going to have 5 or 6. But with more than 40, nowadays it's been demonstrated that it's useless. Okay, it's not working. So, but what happened? That there is somebody, for example, well, I don't want to mention any names of clinic here in Spain, but they think, well, the PRP are used in traumatology, in orthopedics, when I don't know, in tendinitis and things like that, and they improve the growth of the tissues and to health quickly. Well, why don't you do that? Why don't we do that in endometrium if we have a very thin endometrium? Well, I've done many times because that is not an aggressive thing, and I haven't seen any endometrium getting thicker, better after doing like an insemination. Probably we're doing this in a wrong way, okay? Then you do that, and maybe the patient who had 3 embryos transferred and very thin endometrium gets pregnant. You say, perfect, this is working. No, you need a very serious paperwork with many patients because maybe you are damaging patients. And then what happened then? You publish that. Even that patient write in internet and say, look, I did that in that clinic and I've been successful. And all patients go to that clinic because they're doing that quite innovative thing, right? And then if they are doing that, why I'm not going to do it? So that is a vicious cycle in which we come in because we're doing things because before it's demonstrated, and women are desperate to get pregnant and to have more eggs. And then in the same way that we have the endometrium, we have the ovary. And then you say, well, if we put that fraction with the platelets is inside the uterus, like when we do an IVF, and then we put that fluid, the liquid inside the ovary, then it's gonna come more eggs. That is not happening. It's not happening at that age. Sorry. Mm-hmm. So I understand the anxiety and in the way that she is and trying to do that. So what I would recommend is, look, 44 years old, that it's going to end in ovarian egg donation. I don't know if in England, I think now it's very difficult to do it. Here it is easier because it's completely allowed and well, we have more, it's easier for us to do it. And then I've received many patients from abroad, from Morocco, for example, Muslims, that they are needed to get pregnant, etc. And then we have to say, okay, after just, if the patient has 45, we are not going to do any more IVF because this is not ethical, right? We have to, and some friends says 43. Well, I know patients that at home gets pregnant at 33 or 44. These are not the population that comes to an IVF clinic, right? But at least, well, it's very difficult for the patient to understand. I'm 44 and my grandma or my friend was pregnant at home at 44. Well, we do it. But 44 with the quality of eggs and the low number that normally a human being at 44, they may produce after stimulation. So I wouldn't recommend it. Well, it wasn't because she was 44, failed IVF, cycle, 2 embryos transfer, 3 days, and then failure of implantation. It was told to have a large polyp. Of course, the polyp has to be removed. That's, of course, sure. And this month having right in Spain. Anything else you can recommend to maximize? Well, you have to have faith, and if that is your decision, go and do it. But I wouldn't be faithful if I told you, okay, that is the best thing and you're going to get pregnant. Age is today is not a problem solved.
Of course.
PRP is not, I'm afraid it's not going to be the solution.
Okay, thank you for your advice here as well. Of course, it's important to remember about that as well, definitely. And let's have a look. There are like 3 questions left, or 2, if I'm seeing correctly, and we will be finishing. So if there's anything else you would like to add, please go ahead, type those in right now. And if you can repeat, did you say we should take out posterior intramural fibroids?
Apologies. I'm asking this again. Did you say we should take out posterior intramural fibroids? Well, if those intramural fibroids have, in general, I said how difficult it is to take this decision sometimes. But if that intramural fibroids is pushing the cavity, making the cavity narrower, and is quite big, then it's generally accepted that the patient is big. I mean, more than 5 centimeters, for example, should be removed if possible. But now I've got patients here now having treatment in which we have decided not to do it, because not all patients are the same, or even because she has decided not to do it, because it's something that is not desired to have, but we cannot say that a woman doesn't have any opportunity to get pregnant if she has an intramural fibroid of these characteristics. But if it's big and it's pushing the cavity, it's normally accepted that it should be removed.
Right, crystal clear. Again, thank you so much indeed. And let me have a look. So if uterus has many scars due to multiple surgeries, is it safe to do IVF?
I understand that she has had, well, yes. I mean, providing the uterine cavity is clean, it's normal. There are not additions inside, but I understand that, for example, she has had she has been operated of fibroids, and there are scars in the uterus because of the fibroids removed, or cesarean sections, right? IVF. Of course, it is safe, but I would recommend to transfer just one embryo, as we always recommend nowadays, unless the patient is more than 40 and she's been treated with her own eggs at more than 40, right? So yes, but transferring just one and waiting if that surgery took place and that the scar is recent, less than 6 months ago, we should wait for the scar to be just completely healed. I mean, 6 months. But yes, why not?
Okay, thank you for yet another answer to the question. One more question, okay? So I had 2 failed transfers with PGT-tested embryos. Did hysteroscopy ERA, EMA, ALICE? What should be next? What should be the next steps?
Well, I can't, as many things, here there are things that are generally accepted, and then every doctor has their opinion. Sorry, give me just 1 second. I'm going to close the door.
Sure.
Hold on. Because we've come to clean the clinic now, and I don't want to have noise here. Right. So, if in my own practice, in the daily practice, if I got a patient with a failure of implantation and then she had a PGT, as I said before, these embryos are gold medals. And then what I mean, that patient has spent a lot of money, has suffered a lot of anxiety, and now meaning that transfer this one of these embryos, and then later on she has a T-shaped uterus, as we said, or something, or additions, and we didn't know that because on the ultrasound scan we couldn't see those additions. So I have to be very precise, and I normally do these things before transferring those very good embryos. So yes, I would do, well, look what did happen. Hysteroscopy, of course. Now with ERA, we call ERA in Spain, the ERA, in ERA. Well, now the last paper done by the people who designed this test, the receptivity of the endometrium, they have published, now it's EV, the clinics, that now at last, after many years, they have studied lots of patients, a very large group of patients who did the the receptivity study, ERA, and another group who didn't do it. And now the results come out that the group that got pregnant was better, was those patients without the ERA. So now they say that the ERA is not useful. Then we start asking ourselves, what are they going to design now? What is coming next? Because if they say that this is not good, it's because now something is now proposed, coming another thing, right? But now the last paper said that then the patients who didn't do the ERA were more successful than the one. So ERA is not useful now. What? Then in the daily practice, we see very rare cases when we did that biopsy and then we changed the timing of the transfer 2 days later or 1 day before, and after 3 embryos she got pregnant. And that is our experience. But that was one patient, and maybe she got pregnant because that embryo was the good one. And the window of implantation is larger enough to admit that good embryo sooner or later. So that is the daily, the life we live. That is our world. Okay. So yes, but I do it. Okay. Yes, yes, I would do the biopsy and I would do the hysteroscopy because I want to have everything covered before wasting, or using those embryos. Okay.
That makes perfect sense. Again, it's never black or white for sure, but this is how you said we need to cope with, I'm afraid, right? I believe that was our final question. So thank you so much, everyone. As you can see, Dr. Garcia, there are some thank yous. That was a very useful presentation. Couldn't agree more. Thank you for your honest advice. Thanks for the presentation. It will be available tomorrow on our website, myivfenses.com, but also on our YouTube channel. You will be able to see it. It will be uploaded tomorrow. Okay, so thanks a lot, everyone. I know that you found this very useful. Dr. Garcia, it was great to have you here. Any final words before we finish for tonight?
Well, thank you. Well, sorry if my English is not as good as used to be. It's now more than 20 something.
It's all okay. Trust me, it's all okay.
28 years since I came back from Manchester. Now, well, I'm practicing sometimes with my foreign patients, but now, well, I have to. It was a bit more difficult than some time ago. But well, I hope that you understand me enough to go ahead with this presentation. Thank you.
For sure, and I'm looking forward to some more events soon enough, of course. As I've mentioned, this is our final webinar this year, but of course, we will be back next year. So everyone, thank you so much for meeting us almost every single week, because we are having webinars every Tuesday. We will be back actually in January, in the middle of the January. So I hope you will be able to join us and register for our upcoming events. They will be available on our website soon. And of course, thank you so much. Thank you, Dr. Garcia. I do hope that we will have another chance to do another great webinar. And everyone, whether you are starting your journey or you are in the middle or waiting, I hope that you will be able to have some positive news. Merry Christmas. Fingers crossed. As always, we will be back. We want to support you. And I really am looking forward to see you all here next year then, okay? Thank you so much indeed. Take care. Good night.